Okay. Good afternoon, everybody. First of all, apologies for not being Dave Marsden. It's a real shame that Dave's not here. He is ill, but he's also due to be receive an award later on in the proceedings, the Paolo Pertica Award. So I'm going to attempt to deliver Dave's presentation. It's a presentation I first saw about 9:30 this morning, so hopefully I'll be able to steer some kind of clear course through it. So first of all, I'll give you a little bit of an overview of the presentation. So I'll tell you a little bit about the organisation we both work for, Combat Stress. Talk about some of the challenges that were thrown up to us, how we responded, how veterans and their families responded and added to the impetus for some of those changes. A little bit of talk about what the model is in the community, in criminal justice settings, and a little bit of a case study towards the end. So Combat Stress, for those of you who don't know, it's the UK's largest mental health charity for veterans. Founded in 1919, at a time when shell shock, as it was then called, was first starting to be acknowledged, and it was a group of women that got together to start to look at the kind of support that they could be offering some of the people that were emerging from the First World War with physical wounds, mental wounds, and some pretty damn serious wounds to their souls as well. Currently, Combat Stress, we have 3 residential centres which focus on treating post-traumatic stress disorder. We also have community teams out across the UK, consisting of welfare officers, which will be looking at practical needs. Are you getting your army pension? Do you need housing, etc. Mental health nurses, mental health staff, and occupational therapy practitioners, looking at, so what else are we going to do? Because one of the big issues facing many people as they leave the armed forces is a complete lack of an identity, or they've lost the identity that they had, and nothing's been put there to replace it. The army and other forces are becoming better at handling the transition from armed force careers into civilian life, from one identity into another, but we're only just starting to scratch the surface. And a lot of this is emerging because of the feedback that we're getting from veterans. But I think actually the people that we hear most from, and perhaps respond more to, are veterans' families. One of the issues we face is that we have high numbers of people who are showing symptoms of PTSD, and we're not able to provide the treatment because the prevailing philosophy at the moment is that PTSD treatment will not work while people are still using alcohol or drugs. There is an emerging body of evidence which suggests that that may not necessarily be the case in every setting. But it meant that a lot of people who needed that treatment were being excluded. And in many ways, this is exacerbated by the one substance that in the forces is used to celebrate, and it's used to commiserate, and it's used to cope, which is alcohol. So that culture of alcohol being there for positive reasons, alcohol being there for negative reasons, actually exacerbated this issue facing people who were showing PTSD symptoms, but maybe also other depressive diseases or anxiety, etc. And what did we do in those days? Well, we would do our best for those people who, during the course of an assessment, it emerged that they'd got substance misuse issues. We'd do our best to be signposting them to other parts of the social and health services, to drug services, to alcohol services, etc. But the feedback that we were getting from veterans and from their families was that these services weren't really geared up to meet the specific needs, not necessarily of just veterans, but of veterans with mental health issues, veterans that may be isolated in their own home, veterans that may not be able to get on a bus to get to the treatment service in the first place. And in fact, I know Dave himself did one piece of work where he spent 3 weeks getting on a bus with somebody just so that they could actually make it eventually under their own steam as they become more and more confident in this to actually get to the treatment services. So we involved partners and veterans in the design and certainly having something that really hasn't been mentioned very much today, but certainly having a Facebook page allows us to listen an awful lot more, sometimes uncomfortably, to what people want to say to you, so that we can incorporate that into our planning. But we involved veterans in the design of the service, and we started to change things like where will we meet people, how will we meet, and what areas will we cover? Because I used the term earlier, an injured soul. This isn't just about health. For some people, this is about meaning. Yes, I know I'm ill, but what's the point? Why recover? There's no meaning in my life. So unless we're addressing health and quality of life in that rounded sense, then a lot of what we're going to be saying to people is not going to be heard and certainly not going to be meaningful. So how did we start to fill that gap? Well, luckily, veterans issues is a very charitable, friendly. We are the deserving poor, not the undeserving poor. So the money was put forward from the National Lottery in Scotland and from the LIBOR Fund, which is where recalcitrant bankers were penalised for manipulating interest rates, and the government decided to use that fund to support what they call the Armed Forces Covenant. So first of all, I'll focus on the challenge in criminal justice work, and I think the reason Dave's included this in his slides is that the award is being given later is for innovation in substance misuse and criminal justice. But veterans are widely considered to be the largest occupational group in the UK prison system, but we don't know how many. Estimates, even official estimates, vary between 5 and 17%. Probation figures are equally as patchy, as are any interventions either within the prison system or in the probation service, which have actually considered what the issues facing veterans might be. There's no clearly targeted or funded interventions. There's smaller interventions which are quite voluntary, like veterans in custody, etc. And the Home Office and Probation Service are desperately trying to clarify the situation. But the one thing that every agency in this room that's providing direct service provision to anyone could do would be, a good start would be to ask, were you ever in the armed forces? Have you served in the armed forces? And depending upon the response to that, there may be a whole series of questions. In fact, it could almost be a whole domain of an assessment form about, okay, what do we need to do to try to meet the needs that you're presenting us with? In the armed forces, some 13% of those deployed to Iraq and Afghanistan are thought to suffer from significant alcohol disorders, much more likely than the general public, as it says on the slide, to be homeless, to be in prison, to be isolated, to have undiagnosed mental health conditions, including PTSD. And this is a really important one. We think everybody knows about services. So many veterans just do not know what services are available to them. So unless we're asking those questions, unless a GP is asking those questions, unless a dentist is asking those questions, unless a drug worker is asking those questions, we're never going to find some of the responses. So yeah, unaware of services, and even when they are aware of services, find it very difficult to sustain any contact. There's poor transitional support for people leaving the forces. There are issues of shame. There are issues of identity. And the 12 years at the bottom, 12 years is the average time from the end of service until somebody presents for a treatment for their PTSD. Usually, during those 12 years, they've been trying to cater for this themselves. So the families have been trying to deal with it, and the veterans themselves will be trying to deal with it, often through alcohol. but often through a lot of other substances as well. So in response to the funding that was given to us by LIBOR and the National Lottery, we mapped out the prevalence of where veterans are living within the UK. And depending upon what services were available in particular areas, who the partners might be, what the local political will to support this was, we've set up a whole series of services mapping across the whole of the UK, right up to Glasgow and the Forth Valley in Scotland. So looking at the model, what we were told was what people didn't want another service that they wouldn't know about, another service that would be treating something inappropriately. What they wanted was something to help them negotiate their way through the systems that are already there. So it's case management, it's not treatment. We're supporting people, we're advocating for people, we're trying to empower people, and we're setting up peer support networks in the areas where we're working. We're looking to overcome pride and stigma. Now, assertive outreach is a term that's used quite a lot. This is pretty damned assertive outreach. We won't discharge someone from our books for not complying. We won't discharge someone from our books for not attending appointments. We'll go out and we'll find where they are. We'll find out what the issues are around compliance, etc. And unless we're accused of stalking, then we're not going to be letting them go. We'll be there to provide that support to ensure that they're getting the services that A, they need, and actually B, they deserve. Advocacy and the promotion of self-advocacy is a big part of the work that we do. And in many ways, as with many substance misuse services who will bounce off mental health services, and as with many mental health services that will bounce off substance misuse services, that's still a difficult chasm to bridge. But one of the benefits of working for combat stress is that we've got a whole plethora of consultant psychiatrists, psychologists, etc., who can be making referrals at a different level from a typical drug service worker trying to make a referral to a psychiatrist. So I think our referrals tend to be taken a little bit more seriously. We're negotiating pathways, but a big part, and half of what we're funded to do, is to be raising awareness and working with other agencies for how can you become more veteran aware? How can you become more veteran friendly? So a lot of veterans, when they enter a room, the first thing they'll be looking around for, are there any arms in this room? Are there any threats? Is there somewhere where I can sit with my back to the wall so that I can survey the whole room so that I can feel safe? It's surprising how many waiting rooms that you'll walk into in any service where that is not the case. So in terms of retaining veterans, if they're already feeling uncomfortable as soon as they walk into a waiting room, how likely are you going to be retaining those people in services? And yes, this is about hard-to-reach services, not hard-to-reach service users. The service users are pretty easy to reach. It's actually getting them to the services which is the hard part. So we have our traditional map of partners. We have our statutory services, the NHS, health services, veteran-specific services, probation services, housing services. But in terms of the network of pathways that we're building, we're also looking at trying to build some quality of life into this, some spirituality, which sounds a strange word to be using, but when the meaning's gone out of your world, sometimes that spirituality is the very thing that's going to empower you to make the health changes that you need to make. And I suppose in many ways, just to throw a few kind of key buzz phrases in at the moment, this is a truly asset-based community development, leading to asset-based individual planning and genuine co-production of each individual care plan with each individual service user. So Dave works with us in Northumberland, Newcastle and Tyneside NHS. It's one of the first pilots, and Dave had been involved in an initiative in Blackpool in the 90s and the 2000s, the Tower Project, which was a criminal justice focused drug intervention. And Dave decided to take some of the learning that he'd got from the Tower Project and start applying it to the veterans' situations. And as I say, there's an equal focus on doing the work with the veterans, but also on doing the work with the services to improve people's understanding. They adopt this warrior down mentality. As I say, if people seem to be dropping out of the service, then we will go and find them. And we keep the caseloads deliberately low so that we've actually got the luxury of being able to do that. And I think that's very important. And as the manager of this service, this is one of the things I'm often battling with our partners with, because we embed people in other organisations and they're suddenly being asked, can you just run the needle exchange on a Monday afternoon? Can you suddenly do this assessment for us? And the answer is no. We're funded to work with the veterans, I'm afraid. Some example of some of the criminal justice links that we've been making. Yes, there's probation. Yes, there's CRCs, police, courts, prisons. But I think one of the most important things we've been getting on, because for many veterans that do offend, often the tariffs of their offending can be very high, very violent, very extreme cases. So we've been invited in Newcastle to be sitting on the MAPA panels. So we're getting more informed sentencing packages. We're getting the veteran question asked of everybody that's coming through probation and prisons in those areas. We're getting increased attendance, so people are not being penalised for not complying with a probation order. We're getting less escalation, they're being taken back to court less often. We're seeing more substance misuse and mental health improvements, and we're currently in the process, in fact we signed this off last week, of developing a project in 4 prisons in Lancashire. But there's still a long way to go. Given time, I think I'll skip the case study. I come from the substance misuse field, where I'm quite used to people complaining about the size of their caseloads, complaining about the amount of data they need to collect, complaining about managers like me. One of the things I find really refreshing about the work at Combat Stress, and I didn't have to pay Dave to put this into his slides, is this is something I hear all too often. This is the best job I've ever had. Thank you.